sort of a discussion back and forth. We'll have the fellows maybe give their wisdom first and then faculty after that, and have some robust discussion. And we have two, I think, really good cases. All of these cases thus far this year have been wonderful, and I feel that I've learned at each webinar, so we appreciate the fellows. And also to remind those that are attending, the fellows spend quite a bit of time putting these cases together, and it's really their show. We have very little input, which I think is great because it'll help for their future careers when they have to give talks. Don't have people reviewing their slides. And so without further ado, Dr. Lindsay Ross, who is at the Mellon Center, which I think all of you know, it's there in Ohio in this place called Cleveland. She's going to take us through the first case, which I'll moderate, and then Jen Graves will moderate the second case. So without further ado, Lindsay, why don't you go ahead?
Well, thanks, Newsom there. And just so you all know, in case you thought something was coming across weird, I have a little bit more content in this presentation than I intend to present, but just some extra slides of videos and details and things in case people wanted them. So you will see me skip a couple of slides intentionally here. So it's not weird on your end, but just go ahead and get started then. So the background of my case here is I have a 50-year-old Caucasian male. He has a pretty relatively unremarkable past medical history, just some hypertension. He had a carpal tunnel release that had an appropriate EMG back in 2015. Family history, only really notable for dad having leukemia. He doesn't know what kind. This gentleman is married. He actually does a lot of handy work. He's a fiber optic technician, and his social history was a little more colorful. He smokes a pack a day, drinks 5 to 7 martinis or rubbing cokes a day. He's not partaking in recreational drugs, at least. And he came to see me first in September of 2020. And there were some logistical complications with this case that I'm sure you all see too. He showed up in my clinic, and the first thing after I said, what are you doing here? He said, well, I've come to see neuro-oncology. And just to clarify, neither myself nor my staff are trained in neuro-oncology. He is just truly showing up, unfortunately, in the wrong place, coming in from out of state, and similar to many other cases presented here, or that we all see, he's already about 2 years into his disease course. He's seen a whole other slew of people in another health system before he even comes to see me. So I went ahead and saw him anyway, a little bit from his chart, and thought maybe we could help him anyhow. But his back,
star. You're a star. Keep going.
So
Lindsay, he probably doesn't have time for any recreational drugs if you see what else he's doing.
Yeah, exactly. Yeah, seeing everyone and their friend for referral. But his backstory starts in summer of 18. He has some low back pain, onset pretty acutely over about an hour. Seeks care initially through pain medicine. He gets some local injections, maybe 6 to 8 times. Tries some physical therapy, really just being treated as degenerative disease and arthritis, given his handiwork. Thinks he maybe got some x-rays, but can't be real sure about that. And his real onset of more neurologic problems comes in summer of 2017. He has more progressive myelopathic type symptoms where he has bilateral lower extremity kind of paresthesias. He has a sense of tightness around his waist. He starts having trouble with his gait, which is more, he thinks, from coordination than weakness per se. He's got some bladder symptoms with urgency. It's trouble maintaining an erection. So in October of 19, he gets a lumbar spine MRI that does show some degenerative changes on here, and is referred initially to neurosurgery. And this is just to compare their exam, which is in January of 20, to what will ultimately be mine, which is pretty unremarkable at that time, but they note some asymmetric hyperreflexia, which prompts them to get some further imaging, and not consistent with just the degenerative changes reported on his lumbar spine MRI. So his initial imaging, I'll run through really just the still imaging just to keep things on time. I have some videos in here too if people have more in-depth questioning, but the cervical cord imaging here on this mid-sagittal T2 on this side just shows disc herniation that's not really deforming the cord, not causing cord signal change, and is not really the source of his problem. And then this is the video slide when we get to the, I will just skip to the still here. Okay, so nope, that's another one of the video slides, and that one is too. And, okay, so this is his mid-sagittal T2 of his thoracic cord imaging. You start to see his T2 hyperintensity, seen a little bit better on his STIR imaging. The quality is somewhat imperfect. He says he's not having a good time laying still here. These are two shots of his axial views. This is actually in his lesion, and it's probably hard to tell projecting. It's a little bit better on the screen, but this is almost a little bit diffusely hyperintense on the T2 axial here. This is a level above that lesion that you saw there. And then this is his post-contrast imaging, which is actually done about a month later. But sort of the mid portion, posterior region of this lesion has some enhancement. And it's really kind of a circumferential enhancement around the side of that lesion. His brain imaging, which they did following that, was pretty unremarkable. He has some kind of scattered, nonspecific white matter lesions. His other sequences, which I skipped for the sake of time, were pretty uneventful too, and this wasn't really terribly surprising given his recreational history to me. All right, so this is still before he comes to see me. He goes to get some other workup, sees a neurologist in another system who does a slew of blood work as well as some CSF testing. I have some abnormal blood work on the next page, but just some ones of note here. Tested for aquaporin 4 and MOG. This was an ELISA, but some other causes of myelopathy, looking at B12, syphilis, HIV, ANCAs. A pretty good set of things that's unremarkable in here that I thought was a good screening. And then in his CSF, he has a markedly elevated protein, but no real pleocytosis, and elevated IgG index without oligoclonal bands and a negative cytology. They also ran ACE in the CSF for syphilis and Lyme. And then this was the abnormal part of his blood work, which led him down a little bit of a different path. So they noticed that his CBC was, he has an elevated hemoglobin and he has low platelets. And then they also noticed on his serum protein electrophoresis that there's this kind of questionable finding where he has deformity of the gamma globulin tracing, and they sort of hedge on it, might be a paraprotein or immune complexes. And in the follow-up of the immunofixation, there's weak restriction and monoclonal band cannot be excluded. And they follow with a UPEP, which was also sort of shows an area of enhancement in the beta region, cannot exclude a paraprotein, but enough to send him to see hematology oncology before he meets me. And I borrowed this from their note, which is a long way of saying that they, they repeat his testing. It's negative. They do other myeloma workup. They test for JAK2. They find that he has elevated ferritin. They look for hereditary hemochromatosis, and they don't really turn up anything. But they still feel like myeloproliferative neoplasm or ITP remain on the differential. And it's all sort of up in the air.
So Lindsay, do you want to maybe pause there and just see what the initial impression is from fellows first, and then maybe faculty?
Yeah.
Don't all jump in at once. So just thinking about the progressive myelopathic picture and the images that Lindsay had shown, what are some thoughts? And even ignoring the hematology oncology sort of impression, because that could be a red flag.
Can you hear me?
Sorry?
Someone?
I missed that.
Can you hear me?
Yeah, I can hear you now.
A little bit.
This is Daniela. So I was just based on his history and his age, when someone presents with a kind of chronic subacute myelopathy, can consider some type of vascular lesion, and however, taking into account his hematologic abnormalities, I guess some hematologic malignancy can also be, there can be kind of a type of lymphoma affecting his spinal cord. I think those but definitely sounds like he's having chronic myelopathy.
What about others? Looking at short segment lesion that we see here.
I'll pull up this subtle-
We said it is enhancing, right? So
Mhm.
mildly enhancing. So, I think most of you will sort of go through this litany of, list related to myelopathies, and I think it's good exercise to do that. But as Daniela had, I think, keyed in on, is age, I think, does become important with some of these chronic myelopathies. And you can see some of the workup here was negative, which I think whoever did the initial workup, was pretty comprehensive, actually. But what other things? So vascular, Daniela said, maybe neoplastic. What is our favorite bucket of myelopathies?
So, hi, this is talking from UCSD. So, I think with this workup, we already kind of have ruled out a few things. Of course, we do want to rule out nutritional etiologies, but it seems like they did a pretty good job in doing that. Then I think just from the time course, like our typical MS lesion, also I mean it doesn't really behave like it, like how its symptoms develop kind of like more subacutely. Also the brain lesions, I mean, do not look typically like MS. It's not really longitudinally extensive like we would see in NMOSD, and once again, it doesn't really fit the time course doesn't really fit. I mean, MOG you could think of kind of more like, because it's more the thoracic spinal cord, so I wouldn't completely take it out of the picture, especially because I guess they just did an ELISA, so it still might be worthwhile checking. But then he has this I think kind of preceding everything, he has had this arthritic picture with joint pain and the joint problems. So it also kind of makes you think of like some underlying systemic rheumatological disease. Was one thing I was kind of thinking of was like neurosarcoid, just kind of because it's this lesion that just continues to be in this one space. I know it's more kind of like the circular enhancement. Sarcoid would be more kind of like the trident picture of it, but it's definitely something that crosses my mind, or like other like systemic rheumatological diseases.
Yeah, and just curious what other fellows think about the time course not being consistent with multiple sclerosis. If you put aside the brain imaging findings, are there subtypes of MS that maybe we can see in older patients that could fit this picture? Sort of a loaded question.
You're right. I mean, like relapse, it's not the time course of relapse and remitting. Of course, we can kind of more in the progressive part. But then he also doesn't have oligoclonal bands, which of course doesn't rule it out. But I think overall it makes.
Well, there's a part of his Bob Lissack. There's a part of his workup that makes MS extraordinarily unlikely. The total protein of 143. So Wally Pergolot, who had autopsy-proven MS patients at the UCLA Wadsworth VA, Wally said a total protein of over 100. He's never seen pathologically verified.
Yeah, no, it's a great pickup.
Even over 75, he would worry about. Whoever that is making more sense than I am. But at any rate, and the IgG index of 0.7, presumably that lab, Lindsay, is what, 0.6 something? I mean, it's not really astronomical without
Right, yeah, the upper limit of normal, I think, was 0.61 or 0.69.
Yeah, so, but that high protein, Wally would have said, you're just not going to see in that. And if he smokes a pack of cigarettes a day, and let's assume he really smokes twice as much, that hemoglobin could be secondary polycythemia.
Right.
Admittedly, he has a low platelet and he doesn't have an enlarged spleen, but
right.
So that may be absolutely red herrings.
Dr. Lissack, for that protein, do you have a top 3 things you want the fellows to think about when you see a protein that's that high?
Sure.
So what are maybe are some of the fellows, when you see a protein that's that high, are there some things that rise, or Lindsay maybe, that rise to the top of the list?
Yeah, I mean, so when I was thinking about this, I was thinking, you know, he doesn't look like he has a matching pleocytosis, but you see the enhancement, and certainly there's a lot of things that could be settling here. But I think as who's ever our fellow from UCSD mentioned, sarcoid crossed my mind, you know, fungal infections. If he had turned out not to be immunocompromised, but that might have been on my radar as well.
Vasculitis, right?
Vasculitis, yeah.
Yeah.
Yeah, I mean, for sarcoid, you don't have to, but you would like to see some cells and maybe a little lower sugar than that, assuming the blood sugar was reasonably, you know, not 300 and therefore 70 would be low. What you often see it with, but I don't see it in the bony structures, is compression. And very high proteins, although this is not astronomic, you see in things like, as you said, fungus and TB, compression will do that. And sometimes compression from a MET will do that. It was so-called Freund syndrome, where it was you, when you did a tap, if it came out yellow and you didn't think it was blood, you didn't bother to pull the needle out. You took the patient down and did a myelogram because you had to assume they had a block. Now, 143 isn't that high. But I didn't see any compression, and compressive lesions can enhance. I think Brian Weinshanker or some of the who from the Mayo talked about, you know, the different kinds of lesions that you see in sarcoid and you see in this, that, and the other thing. And we always tend to think that a compressive lesion wouldn't be enhancing, but they can be apparently. But I don't see any major compression there. I mean, the biggest compression is way up in the cervical, which isn't very impressive anyway, and wouldn't explain the story.
Definitely thoracic cord compression is very unusual. You know, it's usually seen in, as you mentioned, cervical stenosis. Okay, well, why don't we, in sake of time, Lindsay, why don't you take us to when you guys ended up seeing them?
Yep. So let me get through all of this. Okay. So just for sake of reference, that imaging ends up being March and April of 2020. I meet him in September, and as opposed to his neurosurgery exam to start the year, by the time he sees me in September, he does have appreciable leg weakness bilaterally. His tone is a little bit increased in his lowers. He's hyperreflexic in his lowers, somewhat asymmetrically, worse on the right. He actually had some really nice patellar clonus that the med student was very excited about. You know, he had the sensory exam to match. He's even got a Romberg where he's got some moderate sway by this point. He's got a wide-based gait. So he's had further progression since that last set of imaging. So any good neurologist, we repeated his imaging. And I will skip to the still shots as well. So this is his repeat thoracic imaging. We repeated his cervical too, but for sake of time, it remained normal. So this lesion comparison I thought was about the same in size. Actually, you know, it looked a little bit worse to me on our scan, but in compared in radiology, they thought it was about the same. I would say that his disc disease appears a little bit more prominent here, where you can see there is some progression of his degenerative changes. And then this is his post-contrast scan. That enhancement is kind of coming across here if it's a little bit hard to pick out, and kind of remains circumferential on that side. We did some other imaging of him too at this point to look for some of those more systemic diseases that may have crossover into the neurologic space. We did CT chest, looking for both malignancy or sarcoid without findings there, and did abdomen pelvis, which was also unremarkable at that point. And we repeated some serum studies. We did repeat the MOG and aquaporin 4, this time doing cell-based assay. That was unremarkable. And given his concern of this potential hemopathy and the findings on his hematologic evaluation, we did a paraneoplastic panel and actually turned up acetylcholine receptor, the ganglionic one, antibody at a low titer, the 0.1, from that standpoint, which maybe other people know differently, but at least in my review, I did not find any correlation with cord lesions and ganglionic receptor antibodies. He did, interestingly, though, turn out when I called him after this to endorse some dysautonomic type symptoms. He didn't have the most common anhidrosis, but he said that he would occasionally feel lightheaded on standing and some rare episodes of tachycardia with dizziness. He had, bowel bladder dysfunction, but that may have been well attributable to his cord lesion from that standpoint. But we sort of turned this up, perhaps incidentally, as well when we hadn't been looking for it. We also sent him to see our neuro-onc folks who he was trying to see in the beginning, and they felt that this was unlikely to represent a primary neoplastic process, and that, as other people had mentioned, his prior hematologic workup had been kind of inconsistent, and that his hemoglobin could be up from his smoking, his low platelets may be attributable to his drinking, and they weren't particularly impressed by the sort of questionable findings that had been there before, and were just planning to follow him. At this point, he's now over a year into worsening of his symptoms without kind of a clear answer, but he's having persistent enhancement on his imaging. He's got, elevated protein, and we decide to try steroids, first oral, and then he calls me like a month later having worsening kind of back pain, worsening difficulty walking. We ultimately try IV methylpred as well, and he doesn't get any benefit out of this. And he's going to PT during this too, and he's really not sure if they're just kind of reassuring him or if he's actually improving.
What was the oral dose that you used and for how long?
We did 1250 of prednisone times 5 days, and then we did the 1000 of the IV methylpred times 5 days too. And these were
So a good
separated
dose,
by
a good
about
dose.
a month. Yeah,
Yeah, so not just a
6
Medrol
times.
dose pack.
Yeah. Kind help of his local primary care doctor.
That pattern of enhancement, I mean, even though it doesn't seem like this is sarcoidosis based on what you've shown us, but it just looked like the pancake enhancement that has been described for sarcoid.
Yeah, I appreciate that. I kind of thought it was pancake appearing myself. But I guess I'm kind of curious what other people would have been thinking about or next steps at this point.
Yeah, so why don't we start with the fellows? I guess one question would be, what additional workup may be helpful? I mean, you guys did quite a comprehensive workup.
This is Ryan with Rochester. It seems like there's a low concern for malignancy, but at this point, I'd probably do a PET scan to see if there's any other target.
Yeah, I think that's a great idea.
Just for that, definitely crossed my mind too. I'm glad someone else said that.
And PET-CT, by the way, would be very good for sarcoid. We just picked up a case, one of our former residents who's sent me an interesting case and when she did the PET-CT, things lit up and they biopsied the node that lit up and it was sarcoid. So that's probably the most sensitive. Sometimes the insurance companies give you a hard time. So a gallium scan is sort of not quite as good, but we'll occasionally pick things up as well.
Yeah, I'll say the reason we ultimately decided not to do it was just the lack of benefit with steroids. We're like, we just weren't so convinced. We were hoping it would have been responsive if it was going to be.
I'd like to draw attention to a comment in the comment box from Hamza, who wants to know, would you consider spinal angiogram or spinal dural AV fistula?
Yeah, I like that idea too. I guess, when this was persistently enhancing, this is now October, or is that something that other people see commonly with dural AVF, like that persistent enhancement? Maybe
Yeah, you certainly can. You certainly can. I would say by this point in time that you'd like to see evidence of venous hypertension in these longitudinal extensive lesions, will often go with that. But you certainly can see persistent enhancement, absolutely. And in fact, within our TM center, one of the more common etiologies of myelopathies we see is vascular in origin. You know, they get sent to us for transverse myelitis, and probably a good 40% are vascular. And I'd say, the AV fistulas, dural AV fistulas are probably the top type of vascular myelopathies.
There used to be a finding that I think was overrated, and the lack of it didn't help, with finding something in the skin at that level when you Valsalva filling out. But
Interesting.
but that's one of those things. When you see it, it's great, but don't rule it out because you didn't see it.
And flow voids you'll sometimes see on imaging, but that's another thing that I think is under or over reported. If you look hard enough, you'll see flow voids. But I wouldn't go doing spinal angiograms on everyone.
So the AVMs sometimes will have this kind of paradoxical response to steroids too, where people will get suddenly worse. So that is something to think about. If he indeed did get worse with the steroids.
Yeah, it wasn't right when he was taking the oral. I should have clarified it was maybe a couple of weeks later, but it was definitely after that first course of oral that he felt worse.
What about lumbar puncture? Would anyone consider repeating that? I guess the thing that keeps standing out in my mind is that elevated protein. That's really high. And, having essentially acellular LP, but high protein with the central nervous system process, it could be sort of a key in the differential. I think, like Bob Lisek said, it's a sort of short differential diagnosis. So I don't know if you guys consider repeating the LP.
If you repeat it and you see xanthochromia, that might tell you a little more about maybe something bled or something. But I'm not sure that a negative still wouldn't rule out a fistula. I don't think so. I don't know.
Are we at the faculty level, or are we still?
Yeah. I was looking to see where you were, Dr.
I'm waiting. But look, I think Bob made a very important. Stay right there. That's good. That Bob made a very good point about bringing up Freund. But let's be clear that Freund is typically an 800 to 1,000 milligram %. That's when you get the the full
maple syrup coming up.
That's right. But the full actualization of it. So the 140s is not your 800, but a block of some type could be the start of something that is going to escalate if the block continues. So I like the idea of repeating the CSF. The other question is, notwithstanding spinal angiogram and all these other tests, what about a myelogram? Because although Bob says if you look at the axial, it doesn't look, very convincing for significant compression, often what you see is not always what you get, which is why we have these other techniques. So myelography showing a hang up or some block at some point may be enough to rise that protein. There's many other causes, of course, but often you don't, not unusually, and in presentations of conferences like this, you don't see these, what you see is in fact what you get. And in this case, you've got some red herrings, you found some things. Compressive lesions can cause alteration in vascular mechanisms that can lead to breach in blood spinal fluid barrier, can lead to enhancement over time. And if you get enough compression, he certainly is tight on the lateral on these. The axial's not as bad. But, we can embarrass the vasa corona and eventually have a vascular lesion in this cord. I just want to bring up one thing because I can't help but not because of my upbringing. My father was one of the original baseball super agents and was the agent for Dave Winfield. And in 1989, he's a 6'7" guy drafted in all three sports, first guy ever. He had this long, snake-like recoiling of his back. And I was traveling with the club at the time, and he had this excruciating pain in his back, and sure enough, had an L2-3 herniation with a fragment into the cord. It's 1989. So Jen, this was like toward the end of my MD PhD program, which finished in 90. And I looked at these films and I said, gee, this is, I'm no expert on this, but this is, you can tell there's some focal compression. They didn't do a spinal fluid, but he had enhancement to this lesion and was operated on, and it recovered and he went back to play. It's all very well documented. I'm not breaching HIPAA in any way, but that was a more acute lesion. This has been more subacute, but if you look at this guy's history, he's got the pain, the fullness in the lower back. He's got, look at his work history, the kind of work that he's doing. Sedentary guy, you know, it takes time to drink 5 to 7 cocktails, or maybe that's 10 or 12. Well, it does. You got to be hanging out. You're probably not running or exercising during that time. And if it's a pack, and maybe Bob's right, it's 2 packs, it takes time to work as a optical tech, and then, you know, to smoke a pack or 2 or drink all those lesions, all those drinks. And then, you know, come to see Lindsay, who, you know, I got to give her credit. She takes it on, whatever they do. I've had people show up, you know, to the urology clinic thinking it's urology, it's neurology. And because I do neurourology and other things as well, I take them on, you know, and then I send them, and we have great relations with the guys in the other places. But sometimes what you see is not what you get, and sometimes what you see is what you get. And if you go back to this guy's suffering, his history, and you really take the story, he's a good historian. There are very few poor historians. There are poor history takers. This guy's suffering. He's in pain. He has neurologic signs. Is anybody advocating for, while we're moving this diagnostic armamentarium from 2017, whatever, 18, 19, about decompressing or intervening for things other than these temporary fixes of the shots, non-steroidals, maybe more alcohol in order to mitigate this guy's pain? Let's talk about why he's doing that. So I think there's a time when you look and say, this is a pretty shitty, ratty looking spine. We've all seen lesions at corresponding sites of compression. And yes, enhancement can be seen. There's a high protein. I get it. I love the workup. The thinking is great. And by the way, after you mitigate this guy, you can go back to looking at those things, just like Scott and Jen have emphasized in some of our earlier cases since they took over. You keep going because there are people who don't maybe have one. Occam's razor will cut you when you stop. He may have 2 things. He may have an underlying crab and you have time to work it up. But in the meantime, he's suffering. And in this case, what you see is maybe what you get.
So the one other thing about the vascular, even chronically, there are old experiments looking at how you develop myelopathies. And a lot of them were done, some of them were done, this goes way back, I think, to the 50s and 60s, 19s, not 18s, Elliot, I'm not that old. Anyway, and what they did is they blew up a balloon in the space and gradually compressed the vessels that feed the cord. So that's what this guy could be doing. And the lesion doesn't have to be at the level of where the most compression of the vessel is. Great point.
And I think Lindsay and Daniela had mentioned pancake appearance enhancement, which can go with chronic cord compression. It's also the transverse band that's referred to. I think the Mayo Clinic, someone mentioned they have a case series that refers to that. So, So Lindsay, why don't you go on and tell us what you did?
So I'm glad other people thought all those things, and what we did was decompress him. I got some friends from neurosurgery to see him, and they thought that this did look convincing for, you know, myelitis related to his disc disease, and he actually has a number of discs out of place, gets a pretty extensive surgery, and post-op days 1 and day 2, he's already noting improvement. The exam on the floor is composed as opposed to where I saw weakness in his legs. They were now getting 5 out of 5 in his lower extremities. He's noting by day 3, his walking is improving, and his 2-week follow-up, he thinks it's really good, and he's going without the walker now. He still has some numbness, but he's much improved after his decompression. So he's coming back to my clinic soon, and I think that some of the thoughts about what needs to still be done and reinvestigated and going from there, was that the end of the story just because he got better? Hopefully I'll be able to tell you guys soon, but I'm definitely going to go back to rediscuss if he has remaining autonomic symptoms related to that ganglionic receptor antibody, or was that another red herring along the way? But now that he's maybe a little bit less in pain and uncomfortable, see if he still has corresponding symptoms. And if that needs treatment, he's going to come back and see hematology. He has quit drinking and decreased his smoking, at least allegedly for now. But to see if some of those hematologic abnormalities we saw, if those are better with those improvements, and then pending those things, you need to go back and consider, repeating that acetylcholine receptor ganglionic antibody if it's positive, continuing malignancy screen, and if that needs further treatment. But I guess, yeah, go ahead.
So yeah, look, that's great. So the when you get the report back, and it looks like it's Mayo because that's 0.002 and 0.003 are where a lot of those things are cut. They will give you in their report the odds based on the titer of a specific neurologic syndrome and potentially how possible the odds are for an oncologic. And I think 0.1 is sort of just about where you start getting a little more worried than things like 0.03, 0.04. So I think you repeat it because a lot of the other things that he was describing, as you say, are pretty nonspecific. He was still drinking at the time. So I would repeat it before doing another $30,000 workup, well, $300,000 workup, inflation.
Yeah, and I have to go back and look at the report, but I pulled the paper that the Mayo
they
Group put out.
give you
about
the
that.
citations, yep.
And they said so their cutoff was that 0.1, it would be their lower titer, but in that group, they still saw 12% had malignancy.
Right.
So it's low, but he's a guy who could, I suppose.
Yeah, I think this is where you go back to the clinical syndrome that's sitting in front of you, right? And seeing, does it match up with the autoantibody that was detected? And I think the Mayo Clinic has done a wonderful job in sort of, putting these papers out that sort of tie in the autoantibodies with the clinical radiological syndrome. And it, certainly following it over time is going to be important. What about imaging? Are you going to repeat MRI over time?
Yeah, we probably will. Although, I'll say that some of the, I think we were talking about Dr. Flanagan's paper about the enhancement from compressive disease, that some of that can persist even, out even a year later after decompression and things. So I think we might still not know. But of course, should he develop something else, that would be concerning.
Yeah.
But yeah.
Great. Yeah, no, we had a few cases that the enhancement after decompression was up to even beyond 2 years.
Wow.
The reason why we were following these patients is they had been given a diagnosis of MS, and actually were on treatment for MS, and we had to fight with our neurosurgeons to actually decompress these patients because they didn't believe us because of the enhancement, the persistent enhancement prior to decompression. But I think going back to the drawing board on these cases is important from time to time. Look at the brain MRI, like in your case, doesn't seem to be consistent with a immune-related condition. Lumbar puncture didn't show any signs of autoimmunity. And so it's okay to talk with our surgical colleagues and try to work with them. I think Dr. Frohman had mentioned myelograms. In neurology, we don't really do a lot of myelograms, right, or recommend them. So I think that's a brilliant potential other test if you're not sure if there's a spinal block. And, certainly easier than doing decompression as your next step. So just definitely something to think of.
Along with sometimes if they don't have a complete block, what you get is enough of the dye running past that you get what looks like a paintbrush effect.
Yeah.
I'll have
Scott and Lindsay, you guys, we've mentioned the pancake appearance and that paper from the Mayo Clinic. Maybe we can get a link to that to Doris to send out to all the fellows. But I remember from that paper, one of the key features is that you see the enhancement below the level of the compression, that you would rarely see it above it, because one thing that does come up is a lot of MS patients do tend to get their lesions around their degenerative disease, and whether that's a connection or just one that we put in our minds as MS specialists, I don't know that we've ever proven, but the MS lesions won't necessarily be restricted in that, both the pancake shape of the lesion, plus also the fact that the compression lesions always extend below the level of the compression. Am I remembering that correctly?
Yep.
So yeah, I
that's-
think you're correct in saying that the enhancement, it's below or at the region of maximal compression, which is, I think, where that sort of spinal blood barrier breakdown occurs that people have discussed. And even though in your case, Lindsay, you didn't see a longitudinally extensive myelopathy, but we've seen some people with these really central cord lesions that extend above and below actually where the compression is. And once you decompress that area over time, you see it just resolve completely because of the venous hypertension that's associated with it. So no, great case. I think for all the fellows on the line, you will see these cases just like Lindsay saw by happenstance, not a neuro-oncologist, but she figured it out, right? And
Awesome.
so you definitely will see these cases. That's awesome. I don't know if any other faculty on the line. We have another case which we can get others involved, but Dr. Galetta, Dr. Zamvil, I think I heard Dr. Mowry is on the line.
So this is Dr. Goodman. So just to comment, our neurosurgeons are big fans of CT myelograms, with extension, flexion, particularly in the neck and so on. And they sometimes get it right. When I'm baffled, they sometimes get it right. So it's just something to think about.
Okay, shall we go on to the next case?
Thank you, Lindsay. Great case.
Thank you.
Great. So can everyone hear me?
Yes.
Brigitte?
Let me just pull up my presentation. Okay, great. Well, my name is Brigitte. I'm one of the fellows at USC here in sunny Southern California. So we'll just dive in with this case. And she initially presented to an outside place. So I may not have every single detail, but feel free to ask questions if any arise, and feel free to interrupt me. But this was an 18-year-old, previously healthy woman, college student, who presented to an outside facility with 8 days of blurry vision in her left eye and discomfort with eye movements. So she was initially seen by an ophthalmologist and then a neurologist, and on exam, noted to have decreased visual acuity, color desaturation, NARI-PD, and swelling of the optic disc on the left, and an otherwise normal exam. No neurologic family history. She's a pretty clean living person, like I said, a college student, and not on any medications or any previous diagnoses. So just start off right off the bat here with discussion with localizations and diagnosis, and then next step, get back to the basics.
So we can start with the fellows, but do we have enough here to at least make a clinical diagnosis of some kind? And then what would be your differential and workup at this early phase after you just examined her bedside? And we can start with maybe some of the fellows we haven't heard from yet, or I'll call out some names on the list, but anybody we haven't heard from want to speak up first.
And it's not a trick.
No.
So pain with eye movement and blurry vision with a APD, you're thinking obviously, like we all are, optic neuritis. So you think MS, NMO, MOG, particularly with being able to see the swelling. So you're thinking it's in front of the chiasm where a lot of the lesion might be. So you're going to want to think inflammatory, less likely something like sarcoid or any malignancies. Tons of infectious fun causes can do this. So I usually get my ophthalmology colleagues involved, take a good look to make sure it's not a retinitis mimicking an optic neuritis. So it's not something like Bartonella, for example. And that's usually do a MRI and then a final image to kind of get a better look at things.
Excellent. Any other thoughts from the fellows? Would you do everything? Do you do a broad workup every time you see a presentation like this? There's at the upcoming neuro-ophthalmology meeting in a couple weeks, we had a debate that we recorded about how extensive your workup should be at this point. So anybody want to make any comments about how extensive you might be or what you might start with in terms of testing?
Are you a neuro-ophthalmologist or an ophthalmologist? So,
It still matters, by the way. Glad you asked.
Let's see. Any other fellows? And then I know we also have Dr. Galetta on the line here that we can go to for faculty input. But any other fellows want to comment? Would you get everything? Would you get 1 or 2 tests? What do you do when you face a patient like this?
Do you want me to just start calling people, Jen?
Yeah.
Sure.
All right. Well, we have Dahlia on. We have Carlos Perez. Let's start there. Thoughts?
and don't think too hard, guys. This is just this is bread and butter. You see someone with acute optic neuritis, and you're in the ER. You got the consult. What are you going to do? What are the things that you think about?
And I promise it'll be a better answer than what was actually done. So.
How about Francisco?
No, don't be afraid. They can speak up. Howard has things to say. Come on. You're good. That's the first
thing. If I have to pick a test, I may go for just a lumbar puncture just to see if there's oligoclonal bands present, which may point me more in the direction of a more spread demyelinating disorder.
That would be an impressive move. Skip over any imaging and go straight to the lumbar puncture. I like that.
Oh,
I don't know if I've ever
already
seen
had imaging.
but I guess as long as the CT's okay, I guess I like that.
And it's cheaper than an MRI.
It is cheaper than an MRI.
Yeah, and this whole thing about needing a CT first, when you go and look at the literature, the proof that something's going to happen is pretty slim. Bob Fishman used to talk about pretty imaginary, a lot of this stuff. We once had a patient, we had prepped, didn't even have brain scans, so we prepped his back to do a TAP, and we were then called for an emergency for somebody in status to the ER. When we got back, he had herniated and died. So the conclusion was that it was the betadine.
I see. Okay. All right. Any other thoughts? Or Dr. Galetta, do you want to weigh in on your views of an 18-year-old with this presentation and the extensiveness needed for a workup?
Yeah, it would be nice to have an examination before we did a diagnostic evaluation, right? We don't even know the acuity, but because acuity could be a red flag, and we're always thinking about red flags here, right? So if there was no light perception vision, that's a red flag. We don't know the extent of the disc swelling. That could be a red flag. That is, if we saw severe disc swelling, that would tell us it's not typical optic neuritis. If we saw a hemorrhage, it would not be typical optic neuritis. Now, somebody raised, I think, an important point. If we saw exudate in the macular, then we don't have routine optic neuritis. We have neuroretinitis, and then cat scratch fever and those other entities that were raised do come to the foreground. But so far, we have a story that's typical of optic neuritis, with the only caveat being, for me, that the disc is swollen. And that does add, some thought process about what this might be about, because most of the times, routine optic neuritis, the disc swelling should be very mild. There should be no hemorrhages. And so I'm curious about that. Particularly now, in terms of workup.
Steve, did you say something about the absence of swelling on the examination? And thank you for bringing it up, because we heard in a story a year ago with a nice picture of a tombstone that the neurologic exam has died and been buried. So I'm glad you've resurrected it. But what about the discordance between the bedside exam and what you know about with longitudinal retinal OCT, where acutely we don't see it clinically with our ophthalmoscope typically, but if you look with OCT, we can see quite a bit of edema up into that RNFL, which, as you know, raises the specter of where it began and how useful it is as an inception point. But there is a potential discordance between water and what you see with the ophthalmoscope.
No question about that. It's very humbling, Elliot, that, I would say in terms of microns, you really can't see retinal nerve fiber layer when it's swollen to 110, 112, 113, 115. You really can't see it. But that would, be swollen by OCT criteria, particularly if you have a 6 or 7 millimeter inter-eye difference. That does suggest that nerve is swollen. And I saw a case just like that last week. So you're right. So our rule clinically is that when we look back there, most of the times we don't see swelling. However, if we do OCT, we will see some subtle swelling. But if we're doing this clinically, that appearance of that nerve being swollen to somebody would, raise a, in the back of my mind, is this MOG associated? Is this going to be NMO associated? Is it going to be systemic? And systemic is really most often raised when it's bilateral, when there's bilateral optic nerve dysfunction, or you see uveitis. That's your tip off that it could be systemic.
So Dr. Gletter, you're saying, these are red flags pointing you away from MS, correct?
Yes.
Yeah. I just want to make that clear for the fellows, because I think that's very important. When we think about making a diagnosis of MS, obviously the clinical is very important, but the history and the exam is just as important. And in fact, there was a nice paper in the late 2008, I think, by Miller and colleagues. I'll see if I can give it to Doris to send around, but it went through very nicely sort of the red flags as it relates to MS, and is sort of, how
it's 2008.
2008, I think, right?
Yeah, 2008. It was sort of an accompaniment to one of the updated McDonald, and I think David was the first author on that one. I think it's in JNNP. I think so.
I'm sorry to interrupt, but Jen is on the line. Jen, could you just make a brief comment about this issue of unilateral, bilateral, retrobulbar versus anterior swelling papillitis in the pediatric age population?
I was about to jump in on that point, Elliot.
Thank you.
So everything we just said applies really well in adults. Children are a little different. They tend to have more fulminant inflammation with all of the various demyelinating disorders. And so it is not as uncommon in pediatric MS related optic neuritis to see some disc swelling, but some of the same pearls do apply. You still would never expect to see bleeding, so you wouldn't expect to see hemorrhage with the optic nerve head edema. I have seen hemorrhage in pediatric NMO, and I've seen hemorrhage. I don't think I've seen it in MOG, but I've certainly seen it in infectious and other more rare causes of optic neuritis, but I wouldn't expect to see that in pediatric MS optic neuritis. Now, one problem we do have in the pediatric literature is that a lot of things we published on 10 years ago before MOG antibodies, we have a little bit of a problem. A lot of the things we say about prepubertal MS now have to be revisited and reproven now that we have MOG antibodies to go back and look at those patients. But generally speaking, you are more likely to see optic nerve head edema in a MS-related optic neuritis in a child versus an adult.
And one of the fellows, if I may, as a last point earlier on made, it was a correct point talking about lesions that are anterior to the chiasm, but in terms of what you're seeing on the exam with the ophthalmoscope. But just for clarification, I think what they really meant is come a little bit more forward in terms of before the lamina cribosa versus retro. I just wanted to clarify that anatomic localization. You could certainly have a lesion anterior to the chiasm that's big enough to squash into that region, but generally we're talking about that demarcation of the lamina cribosa where those naked unmyelinated axons are perforating, and then retro laminar myelination is achieved with the oligodendrocytes on the other side. And we know that we have that optic nerve head component response characteristic called the optic nerve head component response, where we go from membrane to saltatory conduction. So it's a anatomically not trivial, very, very important demarcation, but also in terms of what's happening before it versus after it as a demarcation for anterior swelling and inflammation and potential choking of those axons and its axonal transport.
Leib Scheinberg used to say in ON that went with MS is that you look in and you see nothing and the patient looks out and sees nothing.
Right.
So the disc looks pretty normal if you don't have an OCT in your pocket.
Yeah. But if the examiner sees nothing and it's your resident, they usually didn't turn the light on the ophthalmoscope or the wheel was in between. That's why they saw nothing. So I think it's better to say, it's not that you see nothing, it's just that it's normal. And as you pointed out earlier, Steve, about you have somebody who's NLP, this is unusual, but very important to recognize that most patients don't see nothing. They have altered visual issues, but they don't see nothing. So it's an adage that needs to be rewritten and reworded.
Yeah.
It's
But it wouldn't be Leib if it was that detailed.
Yes.
So-
Yep.
Excellent points. And the only other pediatric comment I'll make is that the visual naders in pediatric optic neuritis also can be awful. So we often don't see horrible naders in MS-related optic neuritis in adults, but in a kid, it's not uncommon for them to go almost NLP from just an MS optic neuritis, very different from adults. All right, so Brigitte, there were a few things that people asked about, and I don't know if you come back to them in other slides, but things like the hemorrhages or the degree of the edema that you saw. Do you want to clarify a few of those things before you move on?
Yeah, I'll clarify what I can. So unfortunately, I don't have visual acuity measurements that we have access to from the facility that she was first seen at, but I believe it was more in the moderate category, not very severe. Certainly not no light perception or motion only or finger counting only, something better than that, just from talking to the patient. And there was no comments when she was initially seen about hemorrhages. The only comment was that there was swelling seen.
And she was seen by an ophthalmologist. So from the neck down, nothing was probably recorded at her first visit, right?
She's also seen by a neurologist.
Oh, a neurologist. Okay, well, hopefully there's something.
And neurologist, so I think she probably had a pretty good ophthalmologic exam and neurologic exam, and there was nothing else abnormal on her neurologic exam from the neck down.
Okay, go ahead.
Great. Well, I think some degree of workup would have been great. What they decided to do was to go ahead and empirically treat her with 3 days of IV Solu-Medrol. She noted about 80% improvement in her vision, just subjectively. And then 3 days later, she went back to the emergency room with return of her worsening blurred vision and return of pain with eye movements.
So William Osler must be spinning in his grave right now.
Mm-hmm. Yeah.
Yeah. So
diagnosis. We're seeing too much pathways without thinking.
So at this point, they went ahead and they imaged her. And I'll just let everyone look at this a few times through. This is her FLAIR image. And it's going pretty fast just because I'll let you go through it, but there's nothing abnormal. And I'll make sure everyone agrees with me one more time through maybe.
Oh.
Although that, I'm sorry, that left retro sort of orbital film on the left behind the globe looks a bit stuffed to me.
Yeah,
that doesn't look normal.
That's a big nerve.
Thank you, Steve.
Now we're really getting to see it.
Yeah.
Thank God for Galetta.
No, I'm thanking you.
So
you're my
was there.
You're my mentor. Steve told me years ago, Elliot, never try to see with your eyes closed.
We have at least 3 of the Brooklyn boys on right now. So
That's right. Thinking is okay, but seeing should require you opening your eyes, and you can see deeply later. But
yeah, so it's a big nerve that enhances in a long segment enhancement. So that really raises big time, not a typical optic neuritis case, and shifts you to usually MOG or NMO.
Yeah, so that was my next point of discussion, and I have some stills, hopefully if anyone got dizzy there. And I also brought up the coronal sections as well to look at her nerve. But on this slice, you can see there's more diffuse, on the rightmost slice, there's more diffuse enhancement, and then more of the sheath in the middle, as well as this longitudinally extensive enhancement and thickening of the nerve.
So what do the fellows think? We've said on prior conferences, when we see perisheath enhancement or periorbital fat enhancement with a longitudinal extensive lesion in the optic nerve, it certainly raises some red flags for me as it relates to not MS. And I think Dr. Galletta had mentioned a couple of the diseases that you can see this.
Yeah. So fellows want to revisit the differential after this imaging?
So this is Rosemary, somebody just posted it in the chat as well, but my first thought is MOG.
Absolutely, definitely on the list. Other than MOG, which often seems to be the answer these days when we get optic neuritis, at least with a fairly normal brain imaging, what else can cause sheath enhancement, just to flesh out your differential? It's really good to have because there are some things you don't want to miss.
Would you also consider Behçet's, Sjogren's, or lupus?
Absolutely, they can. Those are on the list. So good suggestions. Other thoughts?
Mm-hmm.
I've got a patient with granulomatosis with angiitis who has perisheath.
Right.
Absolutely.
Yeah. Behçet's is about 90% male to female. It's one of the unusual ones where the immune-mediated risk predilection is the opposite. I had a girl who is the sister of an MS patient on a plane to come see me on a Sunday night from Colorado. I was at my son's ice hockey banquet. The father, gynecologist, called and said, you take care of my MS patient daughter. Well, I've got the other one on the runway in Denver coming to see you. I think she's had a psychotic break. I said, oh, and coming to see me. And she arrived around 10 and examined her, and she was playing with her hair, and she was clearly altered. It was a very interesting break, but here's where the exam comes up. So this was clearly behavior they had never seen. It was about midnight. We were examining, taking a history, looked in her eyes. I was absolutely convinced. She had sheath that you could see ophthalmologically at the bedside on both sides. Now, maybe I was imagining this, that there were floaters and snow banking, and this was before we did the general medical exam, and upon that general medical exam revealed a supraclavicular gigantic Virchow's node on the left, and tapped flow cytometry, 800 white cells, mostly lymphocytes, and this was the form fruit. They removed the entire node for non-Hodgkin's lymphoma, diagnosed in less than 24 hours. This is a paraneoplastic syndrome. She got treated about 10 years ago. She's in remission, 5'10", beautiful Ford model in New York. You'd never know it. All her hair grew back. Mine didn't. But this was actually detected on our exam at the bedside at midnight. I had my friend Nick Hogan from Neuro-Ophthalmology take a look with me. And then later we had more sophisticated imaging, and you could see it on both sides. So in this case, it's more systemic, obviously, 800 white cells. And yeah, so this was a new kind of psychotic break. It's called not a psychotic break. And it was a paraneoplastic behavioral syndrome, like something I'd never seen before. She had very long hair, and she was playing with it and just, flirting with the young residents in the room. It was really quite an interesting show. The father was crying, but the exam was just a bedside exam, feeling, doing the exam, ophthalmoscope in hand, light on. It was not normal. Next morning was cats out of the bag. It was very abnormal.
Yes.
What about chiasmal involvement? I think that we can talk a little bit about it. Was there chiasmal involvement in
Yes.
in this in
Yes.
person? No, I'm
Yes.
talking about the case being presented.
Sorry. Yeah, sorry. I'm sorry. I'm on.
No chiasmal involvement.
No chiasmal. Okay, because I think that sometimes can help with the differential as
Jan?
well.
It's
Yes.
Scott here.
Hey, Scott.
Am I good? Before the dogs bark, I just wanted to say Steve brought up the other diagnosis, the big one there, NMO, and I assume, was alluding to AQP4. And for the simplistic non-neuro-ophthalmologist that I am not a neuro-ophthalmologist, can you say something about the topology, not just MS with MOG being more extensive anterior to the chiasm, but this segment there with AQP4? What are the different patterns for those three, MS, AQP4, and MOG?
So the classic things that apply, again, I'm going to put the caveat that apply in adults, because I tend to see very extensive lesions in children. There seems to be an age component as well. But in adults, MOG is thought to be more extensive, but involving the most anterior part of the nerve, whereas in NMO, it might be very extensive, but classically involving the chiasm, the posterior components of the nerve. I will tell you, I've had a very dramatic, in fact, I wish I had the picture to show now, recent MOG case, though, that very much involved the chiasm, involved the tracts, and involved the optic radiations. One of the most impressive MOG cases I've seen. And in fact, maybe, I'll send a picture around. I've never seen the anatomy of the posterior visual pathway highlighted so beautifully in a very aggressive MOG case. So there are exceptions to the rule, but what has been published is that the anterior, it's extensive, but anterior for MOG, but more posterior with NMO. Bilateral is something that makes you think about NMO and MOG, but again, a little less applicable in children, where we see a lot of bilateral optic neuritis in all three of the big diseases, MS, MOG, and aquaporin. And again, sheath can be involved in MOG, can be involved. I've seen it in NMO. Edema, we've already discussed the optic nerve head edema, more likely to have in MOG and NMO than in MS. I have not seen hemorrhages with MOG, but I have seen hemorrhages in very severe NMO cases very rarely. Did I hit all the ones you wanted to cover, Dr. Zamvil, or
did.
Then you want to flesh?
I wanted to bring it up because we have been at N2.
Yes.
The editors are very favorable about getting the papers in about topology of the lesions between these, and it's a topic of interest, I would say. And this is a very simplistic, potentially simplistic case at this point. Potentially.
Yeah, I just want to emphasize that MOG can have hemorrhages, and I'll highlight a case that is important, reported by Vivek Patel, and this case is going to win the case of the year for JNO, Journal of Neuro-Ophthalmology. But anyway, it's a COVID-related case in which the patient presents with bilateral visual loss and is discovered to have MOG. And presumably the COVID infection may have uncovered the MOG antibody that this person was predisposed to. But in the right eye of that patient, who had very much severe bilateral disc swelling, more on the right than the left, the right eye had hemorrhages. And so hemorrhages can definitely occur in association with MOG optic neuritis. But I'd like to emphasize MOG optic neuritis, I call it the 50% rule. 50% of the time, the visual loss is going to be bilateral. 50% of the time, you're going to have optic perineuritis. 50% of the time, it's going to be recurrent, or 50% of the time, therefore, it's going to be monophasic. And 50% of the time, there's going to be disc swelling. It actually is much higher than that, but at least 50% of the time. So the 50% rule can help you with MOG. And I agree with Jen that most of the times when you see chiasmal involvement, it favors NMO over MOG, but MOG can do it too.
What about recurrent frequency in children, though, with MOG, Steve? Can you comment on that? Do you think it's the 50% rule there, too? I've heard Jeff.
I can't. I don't have the experience to comment on that. I would say in general that the kids tend to be more monophasic.
That's what Jeff Bennett tells me all the time. Yeah. Jen, do you agree?
Well,
more likely, not ever, but more likely to be monophasic.
I might flip it around the other way to say that if I have a kid who comes in with isolated recurrent optic neuritis that appears mild in terms of visual recovery but looks horrible on OCT, I'll put my money down that the MOG antibody is going to come back positive. So I'll flip it on you to say that if, going with the clinical phenotype first, that if they have isolated recurrent optic neuritis, good visual recovery, but a very pale disc and lots of retinal nerve fiber layer loss on the OCT, I'll put my money down the MOG comes back positive.
What about the steroid response here in this particular patient? Any comments on that in terms of differential? Because, they had 3 days of steroids, 80% or so better, and then obviously came back with worsening, but that was after not having a taper. So I don't know if that helps. I mean, it helps me when I think about sort of what this could be or what's higher on the list of the differential. But I don't know what others.
MOG can and should be usually steroid responsive, and it can behave like a steroid dependent, almost Creon-like presentation. And I do put those patients on really long tapers. For that reason, as I transition them, I'm sure, I want to hear from everybody else how you handle it, but they can rebound really quickly without a taper or with sudden withdrawal of steroids, or at the end even of their typical taper, which is sometimes what happens in the monophasic cases. You quickly find out that they are going to be recurrent because you've treated them, have not put them on a medication because you're going to give them a chance, particularly if it's a 12-year-old kid. You're going to give them a chance to see if they'll recur, and often that recurrence will happen as you taper the steroid.
Yeah, it's just the brisk response to steroids. Just in my view, it seems MOG-ish, granulomatous disease. I put in sort of that category as well. NMO, I would be very unusual for NMO to respond this quickly to steroids. We're usually already having a Plex catheter in the person.
Bingo.
And getting their first Plex treatment.
We've stopped waiting. Yeah. But Jen, you made an interesting comment about going back and looking at some of those kids now that there's MOG antibody. It'd be interesting to go back and look at some of the Creons.
Absolutely. In fact, even I think the author of the original Creon paper will tell you that they think at least a third or half of their cohort were probably MOG.
But moving along with this case, we'll get to one of the other issues.
Yes.
A little bit later, the titer.
Great. So that was a great discussion. And just to remind everyone, this was a nice little chart I found, which kind of puts the imaging findings together with the etiology by Dr. Bennett. And as has already been noted, the imaging findings are really most typical for MOG or granulomatous disease. And there are a few other rare infectious paraneoplastic things on the differential as well. So she got some serum lab work at this point, and her MOG came back positive 1 to 80. The alkyl 4 antibody was negative, and then she had some other inflammatory infectious studies sent, which all came back negative.
Oh, I wouldn't call a SED rate of 21 negative in a young woman.
I'm
sorry. And a CRP for sure. I mean, 21, most young women, you say 14, 13, 15, but CRP of 46? No.
That's enormous.
Yes, very elevated inflammatory markers. Otherwise, ANA negative, anti-Jo negative at the time, and then infectious studies negative.
No preceding infection or coexisting infection?
No pre-existing or coexisting infectious symptoms.
We have to stop thinking about ANAs as an inflammatory marker. It isn't. Okay. SED rate and CRP and ferritin are inflammatory markers, as are polyclonal immunoglobulins and haptoglobin and things like that. ANAs and things like that don't necessarily have to be inflammation. It's a sign of some immune derangement, but it's not necessarily inflammation. We see it in myasthenics who don't have any other autoimmune disease. 1 to 160, not a big deal. So we see it. But we don't see CRPs of 46 in myasthenics if they don't have something else going on.
All right, so she got treated with more steroids. She got 6 days of IV steroids, and then she had an 11-day oral steroid taper. And then towards the end of the steroid wean, subsequent days following cessation, she developed progressively worsening positional headache, nausea, vomiting, lethargy. She then had a seizure. She came back to the emergency room. So on exam at the emergency room, she's quite sleepy. She's able to follow some simple commands. She has a stiff neck, and she's nothing else focal, able to move and respond to stimuli in all 4 extremities. So she got re-imaged. And I'll let this scroll.
Not sure if everybody's catching it. Are you going to scroll one more time?
Yeah, we can let it go through one more time. If anyone has comments, or else I can walk you through it.
It looks abnormal.
Yeah.
Yeah. The cortices look a bit abnormal, maybe post-contrast.
Looks like she has lack of focal, suppression on flare.
Yep.
Excellent. Yeah.
We're going to see cortical laminar necrosis or watershed, swelling, congestion.
Meningeal enhancement.
Yeah.
I think flare hyperintensity, and then
the right parietal. Yep.
Right parietal.
Was her stiffness of her neck true nuchal rigidity, or was it sort of postictal kind of muscle tenderness?
I would say it was true nuchal rigidity.
Mm-hmm. And unlike the cases where you see CT with loss of gray-white differentiation, this is the opposite. You have this striking gray-white differentiation throughout.
So then
Dr. Mowry wanted to know about the post contrast.
Yep, here it comes.
I didn't include it. There was some enhancement. It was the leptomeningeal. There was not really impressive leptomeningeal enhancement. There was some enhancement of the right parietal lesion.
Okay.
And so she went on to get a lumbar puncture, and she had 24 whites, glucose of 46, protein of 29, 1 oligoclonal band. And she had a meningitis encephalitis panel, which was negative, which has rapid testing for the most common infectious viruses, bacteria, fungi that cause meningitis encephalitis. Grand salmon culture were negative, and cytology was negative. Before I go on to that, actually, I guess we can pause and see what people would think the diagnosis is at this point.
So, Dr. Mowry, knowing what you've seen on the imaging, what do you think? Does it change? Do you think the MOG antibodies are still relevant or not? How does it change your differential?
I mean, I'm broadening the differential a bit here. I'm a little bit nervous about the systemic inflammatory markers, personally. Yeah, so I'm going a little bit broader here.
I'll just point out that we reported 3 years ago this combination of optic neuritis with seizures as a presentation of anti-MOG syndrome. And often the patients were steroid dependent, like this patient might be appearing to be. And the separation could be a number of years between the optic neuritis and the appearance of the seizures. Max Gutman is the lead author.
Yeah, I think to Ellen's point, she's just concerned about the CRP in the 40s and the ESR in the 20s being, a systemic maybe process. I totally agree. There definitely is meningeal involvement with a lot of the MOG cases that we see.
Yeah, that part doesn't worry me. It's more.
I think Jacob Ruby at our place has had a recent MOG patient with seizures, Steve. So yeah.
But the presence of MOG shouldn't militate against the potential presence of a different antibody or process. Ellen's getting partly to this. But the other question is, were there assessments for the non-onconeogenic cell surface antigen antibodies like NMDA and AMPA, Casper, Gly, all these others?
No, I do not believe those were sent.
Yeah, I mean, a 18-year-old with that story, and you'd be one step away with a second positive antibody to be looking for an occult ovarian teratoma or assessment for, is there a herpetic infection or the systemic that could have raised this?
I guess the panel, the encephalitis panel, I'm not sure, was this the Mayo Clinic or this was just I missed that?
This is a panel that's often sent. It has a rapid PCR as well as antigen identification.
It will pick up
Sounds like
one.
it's infectious. Yeah.
Yeah.
It'll pick that up. 1 and 2 and VZV.
But not the NMDA like Elliot was mentioning.
No, not NMDA. And we know that you can have both demyelinating and the so-called surface paraneoplastic in the same patients, and you can have herpes then lead to the NMDA. That's stuff out of the Mayo as well. So
we published that as part of the N2 section entitled "The Man with Cranial Nerve Neuropathies," in double trouble, and one of those borderline or dual,
And I will say at this point a paraneoplastic was not yet sent, but just to lead people not down the wrong path, there was one sent later which was negative. So just so we don't go down the wrong path here.
This is Scott. I'm assuming this is a CBA, the 1 to 80, not ELISA.
Yeah. Okay. Cell-based testing. Yes.
Still kind of like on the border.
By the way, that was a serum, and that's how we normally do it. But was CSF MOG checked? There's been, again, some increasing reports in the literature about negative serum, positive CSF, mostly serum, but could the titers be different between the two? So is there utility in looking for MOG both in serum and in CSF? Particularly in these cases, as Steve Galetta points out, this is 3 years ago published this combination, but does this signature signal potentially a shift and a change in titer when looking at serum versus CSF? I don't think that story has been completely told.
I'm not aware of data completely answering that question, Dr. Frauman. Yeah. I certainly have seen a lot of pediatric MOG with seizures, definitely could, and some very atypical cortical lesions. Let's see, Brigitte, do you have a few more slides?
Yes.
Okay, we'll let you go through those and then maybe pick some of this discussion back up.
Okay. And I will say what was decided to go here is they decided to treat her empirically with steroids, and she actually had very prompt improvement in her mental status and headaches, and at this point was discharged on a prolonged months-long oral steroid wean.
Out of curiosity, did they start her on an anti-epileptic or just treat her with the steroids, assuming if they controlled the inflammation? Did she get started on an anti-epileptic?
She was also started on Keppra.
Okay.
So it
any IgG4 levels? I mean,
those were not sent.
Mm-hmm.
Those don't really. You really need it in the tissue. The serum levels certainly are all over the place. The range of normal is like 4 to 200 and something, so it's pretty unusual for that to be up.
All right. I thought I had a summary slide. Oh, there we go. Okay, so she actually got started on Rituxan pretty quickly there with the thought that this was MOG. And she then had some ophthalmologic studies. At this point, again, I'm sorry, I don't have the initial visual acuity, but at this point, her visual acuity was normal. And there was actually resolution of the previously seen RAPD. There was some temporal pallor that you were able to see in the left eye, normal visual fields, and then OCT showed diffuse thinning in the retinal nerve fiber layer in the left and some nasal thinning on the right. Normal GCC layer on the right and diffuse thinning on the left. And then I'll just go to the summary slide here. Just to summarize what we have so far, that 18-year-old previously healthy woman, subacute, longitudinally extensive left optic neuritis, which seemed to recur, maybe not quite treated well enough, and then also seemed to have a steroid responsive aseptic meningitis when she was weaning her steroids. And just to remind everyone of what the imaging looked like with her optic neuritis and then her meningitis, and to summarize the studies that were shown. So we were already starting to talk about this a little bit, but at this point, you know, the question becomes, is this all MOG, or do we need to really be looking for other things?
It looks like you checked the antibodies twice. Does that mean you got a 1 to 80 twice?
We did get a 1 to 80 twice, yes. And this was sent a few months later.
Did you repeat
So
the
the
CRP and
interval was
ESR?
a few months?
I do not believe we repeated the CRP and ESR.
Post-steroids, Scott, if it's normal, it doesn't tell you anything.
Yeah. I mean, how far apart were the MOG titers? You're just saying a few months? Just
They were about 4 or 5 months apart.
okay. Because it's something I would want to recheck, you know, certainly if she has recurrent symptoms again, it would be, you know, helpful if that titer were to have gone up. You know, if it goes down, you know, as we think, you know, with more within monophasic course, like in children, you know, with ADEM, we might expect it to go up and down. Here, obviously, with recurrences, we'd expect it potentially to go up, possibly.
That's a good point. In fact, I was going to ask you if you happened to draw it when she was super sick and came in with the seizure versus after getting more steroids.
No,
and then,
unfortunately not. It was, the first one was drawn when she had the optic neuritis, and then the second one was drawn after recovery.
After recovery and rituximab, and probably. One comment I had about the SUD rate and CRP, the CRP is pretty impressive. Something I have never published but have seen, and probably maybe should try to actually formally study, is that she's not pediatric. She's 18, but she's pretty young. And I've noticed that unlike my adult patients, a lot of the young patients we see coming in with acute demyelinating disorders have sometimes somewhat concerning SUD rates and CRPs. And I don't know that anybody has published on that, nor do I know that this is really true science versus my anecdotal experience. But something that I think maybe we've got a bunch of young fellows on the call, we should take a look at, is that in some of the young people, some of whom have turned out to have MOG, some of whom have turned out to have multiple sclerosis that I have seen have bothered me with their SUD rates and CRPs, something that I don't see in adults, and she's kind of on the border at 18. The other interesting thing was, you know, the choice of rituximab, I think is a good topic to bring up here. Obviously, people are using it in suspected anti-MOG disease, but what do we think? We could start with fellows. Taga, I'm going to put you on the spot. What do you think about rituximab? And then also Brigitte, kind of maybe elaborating on your thoughts about jumping to rituximab.
So, first of all, I think just for the question, I mean, I think this all looks very consistent with MOG, and I think if we have that titer with a syndrome that, you know, fits, that titer doesn't worry me that much. I mean, that optic neuritis is, you know, really classic for MOG, and we do see these, you know, these syndromes with also like associated with seizures with this loss of flare suppression in MOG. I mean, rituximab, we have that data. I think that was from Mayo, where rituximab had a pretty high relapse rate with MOG. I think they even like said up it was like 60% or something. So pretty high. I'm not sure.
It's very high.
Yeah, it's retrospective data though. I'm not sure if that's gonna hold up. I know of definitely MOG patients that are doing really well on Ritux, but I mean it's something to keep in mind that maybe MOG patients have not that profound good response to Ritux, and then there's the question about IVIG, where there's some good data, retrospective data showing that there's some there's really like low rates of relapses with IVIG, maybe CellCept in there as well, but yeah, Rituximab, just with that data out there, Rituximab maybe is not quite the first choice in MOG for me anymore, but
well,
I think
you're right. That paper that you're citing, actually, IVIG was the most impressive, and rituximab and mycophenolate and the others were all in the 40 to 60% recurrence rate. But as they point out, it is a retrospective study. But the IVIG was really impressive.
And we are living in the era of COVID-19 and recent observations about the potential worse mortality morbidity characteristics in using anti-CD20 therapies. Doesn't mean it's a prohibition, but it's something we have to think about.
And I've been reminded that we're go ahead. I've been reminded that we're running over time. Let's take a few more comments about
antibodies. The anti-CD20 is Marigny is the group from Lyon that has the largest, it's the Annals paper, not just the Mayo group, which also made it clear from 2019 that anti-CD20 or CD20 rituximab was not as effective, but in individual cases it is. So it doesn't mean that you wouldn't use it. It's just a discordance. Some patients are and some are not.
I agree. I agree with Scott. I think for those cases where you're not sure, is it MOG, NMO? I think in my practice, I usually choose Rituxan. But I think if you have a slam dunk MOGAD case, as Elliot said, in the midst of a pandemic, IVIG is a good way to go first line. And we've had very good success with IVIG. Now, it's a bit cumbersome, of course. I can imagine pediatric MOGAD being challenging, treating with IVIG 5 days, high dose monthly. But it is, I think, a good treatment choice, even over CellCept, in my view.
Well, it certainly has less side effects to worry about than CellCept, at least usually, and in the pandemic era has certainly been a go-to for us. Any other closing comments? Or Brigitte, I don't know if you had one more slide. I didn't want to cut you off, but
yeah. Actually, I have one more really interesting part of this case. So, and just to get back to Dr. Galetta's point, there have been aseptic meningitis in MOG reported in case reports. This was a summary that I found of some of the case reports, so it certainly can be part of the disease. We were a little bit worried about her systemically still, so we actually we got body imaging for her, and we actually found a thymoma. So this is her PET scan, and for those of us who haven't looked at chest imaging in a while, this signal here is in the mediastinum and is diagnostic of a thymoma. So this was the other wrinkle in this case, and I realize we're running a bit short on time. And let me just point out that elevated inflammatory markers have also been quite reported in thymomas.
Yep.
Sorry, go ahead.
I was going to say yes. And the other question is, when you sent the paraneoplastic panel, did that include striatal antibodies? Because they will often come back positive in a non-myasthenic thymoma patient.
I do not believe they were positive, and then when we saw this, we actually went ahead and we resent myasthenic panel, which was all negative.
This is a really exciting observation here, because in the literature, there's not, and when you look this up with AQP4, for someone who's doing all his research on T-cell differentiation with AQP4 and this is one of the nice pieces that make a little report. It'd be nice to see what that tissue actually shows from the thymoma.
Yeah, absolutely. And I went ahead and I went to look if there's anything reported with MOG and thymoma, and and just, it's pretty rare in her age. So even though us adults are especially with myasthenics, used to seeing thymomas, it's pretty rare. And I went ahead and I was looking if there's any thymoma and MOG association reported, and there's not, but obviously thymoma is associated with a whole host of other autoimmune issues, including in the CNS.
This could be the first case of MOG thymoma, right?
And
nice
I
review.
looked this up a month ago. Just for this same thing, just looking for MOG and thymoma and trying to match it and couldn't find anything. You can with AQP4.
It's the black swan.
I don't know
Never
if
occurred
you and
until it occurred.
Christina, what's that?
It's the
Say
story
again?
of the black swan. It can't happen because no one's ever seen it before until it happens.
Right. But I don't know if Daniel or Christina or Liliana or whoever, on this case with you, it's a good one. And anyway.
Yeah, great case. I am trying to be a timekeeper, but it's just such a great case. Any other final comments, fellows, faculty? Such an excellent presentation. Any comments?
I don't want to perseverate over the inflammatory markers, but the CRP being so high, I think, people can have two coexisting conditions, whether the thymoma is related, unrelated, I'm not sure. But I think this is a great case in, digging a little bit deeper when something doesn't sit right with you. At least it didn't sit right with me, and I think Dr. Mowry as well. And
Mowry
so
also, yeah.
So I think it's a wonderful example.
Ben was saying, we see occasionally mild CRP and ESR elevations. And years ago, Mike Phillips with Tommy Thompson in Wisconsin, when Mike was a student, they found mild elevations in haptoglobin and things like that. But that CRP was very impressive, especially some of the assays, the cutoff is like 2 or 3.
Yeah, I mean, if the patient had a rip-roaring viral infection preceding the MOG, attack, the initial attack, which we often will see,
or something like that. Sure.
Yeah, then I'd be okay, but that was just so high. It was incredibly high, and someone who was not systemically ill, at least at that time.
CRP in particular, right? The SUD rate was 5, but the CRP was really impressive.
It was like 46.
So one final point for me, and that is that in MOG-associated diseases, MOGAD, MOG spectrum disorder, whatever we want to call it, unlike with AQP4, we don't see the overlap. We're talking about CRP, but when we talk about Sjogren's and SSA and SSB and the other markers that we see in 25% of patients with AQP4 seropositive disease, in general, we don't with MOG. Just a general point.
Yeah, but they are seen with NMDA receptors. That's been published, overlap with MOG IgG.
Absolutely. Yep.
Antibody, this is just non-specific inflammation.
It'd be interesting to see if it goes away after she gets a thymectomy.
Yeah, it would be. So she's planning to get a biopsy or a resection, depending on what they think they can do, and we're asking it for it to be seen for MOG.
Yeah, absolutely. I mean, this sounds like the liver mets in the case that we published with Claudia's folks. That we found aquaporin 4 in the mets.
Right.
Yeah, and actually,
and Bob, just one last point to you, and that is that there's very limited data that the antibodies in MOG-associated disease at this point are pathogenic in the same way that we view complement-mediated damage with AQP. We have limited evidence, just a few publications of transfer. It's been hard. And so the question is whether it's a surrogate, it's a real disease, but whether it's the antibodies themselves or not, we don't know.
Absolutely. Absolutely.
Is there a reason why your surgeons don't want to just do a resection? I'm trying to see what the advantage is of leaving the thymoma there.
At her age, I would take it out.
Yeah.
I think they haven't done the total plan yet, so we're
Okay.
not exactly sure what they're planning to do.
I mean, if this was a patient with myasthenia, you would take out the thymoma. You don't leave it behind.
Yeah, I mean, the only reason not to take it out is if it's encasing the great vessels in the chest, right? Then you would do radiation.
Right. Yeah,
or
and
debulk
yeah,
it, and
or
then
they
you resect it.
do platinum or something first, and then go back in, or if it's wrapped around both phrenics or something. But otherwise, you take these things out because if they're encapsulated, that's the time to do them.
As Dr. Mowry is pointing out, there's a chance this could be a significant therapeutic even for the MOG, which would be really interesting.
Yeah, it's certainly interesting to
It would
see.
be anecdotal, but it would be pretty strong association.
Save some tissue. Send it to Scott or somebody.
Yeah.
Yes, please. Listen, after this, I'll be writing to Kendall and Christina and Liliana and you also, at USC. It's like, okay, that you really, if the tissue's taken, you want to have it. I mean, first you're a doctor, then you're a researcher. It's okay.
There's plenty, that thing is big enough, Scott. There's plenty of tissue.
All right. Well, thank you, Brigitte. That was a fantastic case. Both cases today were absolutely fantastic. Well presented, great discussions. Thank you, everybody. We'll try to circulate some of the papers we mentioned. Doris can help us do that. Thanks again, all the fellows, all the faculty for fantastic input tonight.
Thank you, everyone.
What she said.
Take care,
Ditto.
everybody.
Thank you.
Great story.
Good night,
Great.
everyone. Thanks.
Good night. Fabulous.